Welcome to the deep dive. Today we're navigating a really pivotal phase in patient care, the preparation for vascular surgery. It's almost like a high-stakes game of chess, isn't it?
That's a great way to put it, yeah. Every move, every single test and assessment, it's all calculated. Calculated to optimize the chances of a successful outcome.
Right, and to understand the board, so to speak, we've really dug into the definitive text here. Chapters from Rutherford's Vascular Surgery and Endovascular Therapy 10th edition.
We're talking a really comprehensive look from that initial broad risk assessment right through to the specifics. Managing the heart, lungs, kidneys, blood sugar.
Adrenal glands, coagulation, infection risk, nutrition, even frailty. Wow, it's a lot, deep and interconnected.
It really is all connected.
Absolutely. So our mission here is to pull out the most crucial insights from, well, this mountain of information. We want to shine a light on the key things medical professionals consider when getting someone ready for vascular surgery.
Exactly. Give you, the listener, a clear kind of actionable understanding without drowning you in overly technical jargon.
Precisely. Connect the dots, reveal the sort of why behind this complex preparation.
That's the goal.
So if you or maybe someone you know is facing vascular surgery, or if you're just fascinated by the intricate steps involved, you're in the right place. We're going to unpack the vital elements medical teams weigh up.
Let's do it.
Okay, let's jump right in. The very beginning, general preoperative risk assessment. Sounds like they're incredibly thorough from the get-go.
Oh, they really are. It all kicks off with a detailed history and a physical examination, really honing in on any cardiovascular risk factors.
Okay.
And alongside that, standard practice is routine blood analysis and an electrocardiogram, an ECG, that heart tracing. It's standard for almost everyone having elective vascular surgery.
And those first blood tests, they seem basic, but they tell you a lot. Complete blood count, electrolytes, kidney function, glucose. What are the key things you're looking for there?
Well, it's fascinating, isn't it, how much these fundamental tests reveal. That complete blood count, for instance. It's not just counting cells. It can flag a hidden infection.
Ah, okay.
Gives a clear picture of red blood cell volume, super important for oxygen delivery, and maybe even hint at underlying blood disorders.
Right.
Then electrolytes, potassium, calcium, magnesium, we're watching those like a hawk. Think of them as vital signals for the heart. If they're off balance before surgery, the risk of cardiac problems goes up.
Makes sense. So you check and correct them beforehand.
Exactly. Proactively. It's a key strategy. And kidney function creatinine and the estimated GFR, that's critical too.
Because kidney disease is common in these patients.
Very common. And some vascular procedures can strain the kidney, so knowing that the starting point is vital. We also look at blood sugar, and for diabetics, their HbA1c.
That's the long-term sugar control measure.
Gives a sense of their control over the past few months. And finally, coagulation tests, APTT, BT, INR, they help spot any clotting issues, especially crucial if someone's already on blood thinners.
So it's like building a really comprehensive health snapshot right at the start. And then there's this ASA classification. What does that actually tell the team?
The ASA classification from the American Society of Anesthesiologists, it's basically shorthand. A quick way to communicate a patient's overall health status before surgery.
Like a score.
Sort of. It's a scale. ASAI for someone totally healthy, up to ASAV for someone critically ill, really low survival chance. But more than just a number, it tells the whole team about the patient's overall resilience.
Okay.
A higher score flags patients who might need, more intensive monitoring, maybe different interventions during and after surgery. It's that holistic view. Super important insight.
Right. So after that broad look, it seems cardiac evaluation becomes a huge focus, which makes sense given the risks.
But absolutely. Even with all the advances we've made, major vascular surgery still carries a significant risk of a postoperative heart attack, a myocardial infarction.
And that impacts survival long term.
Sadly, yes. It can dramatically increase mortality risk in the following year.
Right.
So beyond that initial history, physical, and ECG, sometimes more specialized cardiac testing is needed for certain patients heading for elective vascular procedures.
And you use a tiered system for that: low, intermediate, high risk. Can you walk us through those?
Sure. Low-risk procedures, that's less than a 1% chance of major adverse cardiac events, or ME, in the first 30 days. Think carotid surgery in asymptomatic patients.
Okay.
Intermediate risk is 1 to 5% MACE. That includes carotid procedures in symptomatic patients, peripheral angioplasty, endovascular aneurysm repair.
Right.
Then you have high-risk procedures, over 5% of C chance. This is your open aortic surgery, major limb revascularization or amputation, thromboembolectomy, clot removal.
Got it. And it sounds like how well someone functions day to day, their functional capacity really matters here, this MET-TEAS concept.
Yes, functional capacity measured in metabolic equivalents or MET-T is a really key piece. Think of MET-Ts as how much energy and activity takes. One MET is just sitting still.
Yep.
Activities around 4 MET-Ts. Walking up maybe less than 3 flights of stairs, dancing, lighthouse work, stuff most people do without getting too winded.
And more strenuous stuff is higher MET-TEAS.
Exactly. Basketball, heavy weights, that's 10 MET-Ts or more. Now, patients who are asymptomatic and can comfortably do things needing 4 to 10 MET-Ts,
Yeah.
or who've had a normal stress test recently, or coronary revascularization like a stent or bypass in the last 5 years, they generally don't need more cardiac testing before their vascular surgery.
So it's really when someone's functional capacity is limited or you just don't know it that further tests like stress testing come into play.
Precisely. Stress testing might be indicated for those intermediate or high cardiac risk patients who have poor or unknown functional capacity, basically. Can't do activities needing at least 4 METs.
But not routinely for low-risk patients.
No, routine stress testing isn't recommended for low-risk non-cardiac surgery patients.
Okay. What about patients with pacemakers or defibrillators? Any special precautions there?
Yes, definitely important considerations. Those devices might need temporary reprogramming or sometimes applying a magnet, especially if the surgeons plan to use monopolar electrocautery, a type of electrical surgical tool,
Why is that?
to prevent it from inhibiting the pacing function or causing inappropriate shocks from the defibrillator. And crucially, you absolutely need external defibrillation equipment with pacing capability ready in the OR as a backup.
Right. Makes sense. Now, one area that seems controversial, or at least the thinking has evolved, is beta blocker use before surgery.
That's a really important point. For a while, it was pretty standard to give beta blockers routinely to many cardiac patients before vascular surgery.
But that's changed.
Well, several big trials, like POISE and Decrease of 4, they raised serious questions about whether that widespread practice really benefits all patients.
And the evidence was conflicting.
Kind of, yeah. When researchers looked at the Vascular Quality Initiative database VQI, they actually found starting beta blockers before surgery was linked to a higher chance of heart attack and MBC within 30 days for lower limb revascularizations.
Higher. Wow.
Yeah, didn't seem to impact the limb outcomes themselves, interestingly. And other big reviews haven't shown a clear overall benefit from routine preoperative beta blockers.
So maybe fewer heart events sometimes, but not necessarily lower risk of death.
That seems to be the gist. Some reviews suggest a possible reduction in some cardiac events, but there isn't strong evidence they reduce surgical death risk. And there's even been links to downsides like slow heart rate or increased stroke risk in some studies.
So given all that complexity, what's the current thinking? When should they be used?
Okay, the prevailing recommendation now is definitely continue beta blockers if a patient is already taking them chronically. That's clear.
Right. Don't stop them.
Don't stop them. Now, for patients identified as intermediate or high risk for a heart attack based on testing, or those with multiple risk factors on the RCRI score, it's reasonable to consider starting beta blockers before surgery.
Before, to see how they tolerate it.
Exactly. It gives you time to adjust the dose. But the general advice is avoid starting beta blockers on the day of surgery itself.
Okay, that makes sense. Consistency and time to adjust. What about other meds patients might be taking?
Most other regular meds should generally be continued right through the surgical period, but there are a couple of key exceptions. Angiotensin receptor blockers, ARBs, and ACE inhibitors.
Ah, the blood pressure meds. Why stop those?
Evidence suggests temporarily stopping those specific ones is linked to less risk of low blood pressure during the surgery without increasing the risk of major things like death, stroke, or heart attack.
Okay, and statins. Cholesterol.
Those are different. High-intensity statins have shown benefits, reduced adverse cardiovascular events, mortality, even limb loss in high-risk patients, and those with peripheral artery disease.
Yeah.
So, unless there's a specific contraindication, statins should generally be started before surgery and definitely continued through.
Got it. Now, antiplatelet therapy, things like clopidogrel, that seems like a real balancing act, right? Preventing clots versus bleeding risk.
You've nailed it. That's a critical point. Traditionally, many surgeons preferred stopping drugs like clopidogrel, these P2Y12 inhibitors, before surgery because of bleeding concerns.
But the data supporting that isn't strong.
Surprisingly limited, actually. Several studies suggest continuing dual antiplatelet therapy, DAPT, taking two antiplatelets together, is often safe during vascular surgery.
So maybe a slightly higher bleeding risk?
Potentially in some cases, but that might be offset by a lower risk of cardiovascular events,
No.
like heart attack or stroke. And given how guidelines change for how long DAPT is needed after, say, a coronary stent, it's absolutely essential for the vascular team to talk to cardiology before stopping these meds, especially in the first, say, 4 to 6 weeks after a stent, unless the bleeding risk is clearly huge.
Right, consultation is key there. And what about doing heart procedures before the vascular surgery, like putting in stents or doing bypass?
Yeah, preemptive coronary revascularization,
Hmm.
it's complex. Generally, it's recommended if the patient needs it anyway, regardless of the vascular surgery, like really bad blockages.
Okay.
But a big trial, the GARAP trial, showed that in patients with stable coronary artery disease, doing a heart procedure proactively before a major vascular surgery doesn't actually improve long-term outcomes or reduce short-term complications like death or heart attack.
Really? Doesn't help.
Doesn't seem to, on average. And it can even increase risks from the heart procedure itself and delay the necessary vascular surgery. So current guidelines usually say only do preoperative heart revascularization if it's indicated anyway.
Okay, one exception though, left main disease.
Right. Significant blockage in the unprotected left main coronary artery. In that specific case, heart bypass surgery might be better than stenting before the vascular operation.
Okay, shifting gears slightly. Managing blood pressure during the operation. Sounds like there's no single magic number.
That's absolutely correct.
Yeah.
Both too low and too high blood pressure during surgery are linked to increased risks, but there's no one-size-fits-all target.
So what's the goal then?
The strongest recommendation is for a personalized approach. Aim to keep the patient's blood pressure within about 90% to 110% of their usual baseline.
Their own normal range.
Exactly. For someone who normally runs low, maybe keep the mean arterial pressure, the MAP, like 60. For someone who runs high, maybe keep the systolic, the top number, below 160. It's individualized.
And similar to beta blockers, keeping them on the regular high blood pressure meds is usually best, apart from those ACEs and ARBs.
Yes, that's the consensus. Continue their regular antihypertensives, but again, temporarily hold the ACE inhibitors and ARBs. Stopping those seems linked to less low blood pressure during surgery without increasing bad outcomes.
Whereas continuing them might actually increase risks.
Some studies suggest continuing them on the day of surgery might be associated with a higher risk of those complications, so holding them seems prudent.
Okay, let's switch to the lungs now. Pulmonary evaluation. Sounds like lung complications after surgery are a pretty big deal, especially in complex cases.
Absolutely. Pulmonary complications can happen quite a bit, especially after major abdominal or chest surgery. So a thorough preoperative lung evaluation is critical.
And it starts with the basics, history and physical exam.
It does. And surprisingly, those are often our most sensitive tools for spotting patients at higher risk for lung problems.
What kind of risk factors are you looking for?
Several things increase risk. Emergency surgery, being older than 65, having congestive heart failure or COPD, poor fitness level, being a current smoker.
The smoking again.
Always. Also, long operative time, an ASA class of 2 or higher, and the type of surgery like AAA repair, chest, or upper abdominal surgery, those carry higher lung risks.
So you asked about smoking, oxygen use, exercise tolerance, cough.
Exactly. Any shortness of breath. And during the exam, we listen carefully to breath sounds, looking for decreased air entry, wheezing, crackles. Maybe note if they have a prolonged exhale.
Right, and surgical factors matter too, like how long the operation is.
Yes, if it's expected to be longer than 3 hours or if it's an emergency, that increases risk.
And obstructive sleep apnea, OSA. You mentioned that. How does that fit in?
Yes. OSA is a really important, often undiagnosed risk factor. Patients with OSA are more likely to have low oxygen levels after surgery, maybe even need re-intubation.
So you screen for it.
Yeah, screening tools like the Stop Band questionnaire are really helpful for identifying patients who might be at risk.
Are routine chest x-rays always necessary for the lung check?
Not always. Not if the patient has no symptoms suggesting lung issues. But it's generally recommended for patients with known cardiopulmonary disease, those over 50, and anyone having abdominal, chest, or AAA surgery.
It sounds like the aim is to spot high-risk patients early to put preventative strategies in place.
Precisely. And interestingly, low serum albumin levels below 3.5 have also been flagged as an independent risk marker for pulmonary complications.
Okay, and lung function tests, PFTs.
Routine PFTs aren't usually needed for everyone, but they can be really valuable in patients with known lung disease, helps understand their baseline and guide optimization strategies.
So once you identify someone as high risk, what can you do?
Several things. Smoking cessation is number one, obviously. Respiratory physiotherapy, exercises to strengthen breathing muscles, optimizing nutrition,
And during surgery.
using protective ventilation strategies like lower air volumes per breath, using PEEP to keep airways open, and after surgery, encouraging lung expansion techniques is key.
Smoking cessation just keeps coming up as vital.
It really does. Current smokers have about double the risk of post-op complications compared to non-smokers. Risk is highest if they've smoked within 2 months of surgery.
But quitting helps, even close to the surgery date.
Significantly. If someone's quit for over 6 months, their risk is similar to a never smoker. But even quitting in the weeks just before surgery offers benefits. Physician counseling plus things like nicotine replacement, bupropion, varenicline, they really boost success rates.
And for patients with existing COPD or asthma, how do you manage them?
For them, inhaled bronchodilators, beta-2 agonists, anticholinergics are key. Ideally started at least 5 days before surgery.
Steroids too, sometimes.
Systemic or inhaled corticosteroids might be considered if their lung function, their FEV1, is below 80% and predicted. Using steroids around surgery seems generally safe, doesn't appear to increase death or serious infection risk. And post-op, those lung expansion techniques are extra important for them.
Okay, let's move on to the kidneys. Renal evaluation. You said earlier kidney disease is really common here.
Yes, unfortunately, highly prevalent. A big chunk of patients having vascular surgery have some degree of chronic kidney disease. So a careful preoperative kidney evaluation is essential.
What does that involve?
Asking about symptoms of kidney failure, looking for signs of high potassium hyperkalemia, assessing their fluid balance, checking for anemia, looking for bleeding tendencies.
And baseline tests.
Absolutely.
Yeah.
Baseline creatinine and GFR should be standard. And for dialysis patients, you have to check their vascular access site, make sure it's working okay, no signs of infection.
And potassium levels seem like a major worry again.
They really are. Optimizing potassium before surgery is critical because hyperkalemia can cause dangerous heart instability.
How do you treat high potassium?
Options range from binding resins, infusions of insulin and dextrose, calcium carbonate, and for dialysis patients in non-emergencies, dialysis ideally the day before surgery. Keeping their acid-base balance right is also important.
I also saw something about uremia-associated platelet dysfunction. What's that?
Right. In patients with significant kidney problems, uremia, the buildup of waste products, can mess with platelet function. Platelets are needed for clotting.
So increased bleeding risk.
Potentially, yeah.
Right.
During and after surgery. If that's suspected or confirmed, treatments like dialysis, a drug called desmopressin, cryoprecipitate, or transfusions might be considered.
And you'd hold antiplatelet meds if possible.
Yes, if possible. And you have to be careful with other drugs, too. Even things like diphenhydramine or NSAIDs can have a bigger impact on platelets in patients with end-stage renal disease. And heparin doses might need to be reduced.
Anemia is another common issue with kidney disease, right? Low red blood cells.
Yes, often due to the kidneys making less erythropoietin, the hormone that stimulates red cell production.
So transfusions?
Maybe in emergencies, but generally avoided if possible. They have risks, antibodies, hyperkalemia. For elective surgery, it's better to delay if you can and try to boost their count with erythropoietin, IV iron, B12, folate.
Makes sense. Lastly, on kidneys, contrast dye. With all the imaging done, contrast-induced nephropathy, CIN, must be a concern.
It definitely is. A potential complication when using iodinated contrast for imaging.
How do you minimize that risk?
Using alternative imaging if possible, limiting the dye volume, using specific types of contrast, non-ionic, low osmolar, maybe using CO2 as contrast sometimes. And good hydration with isotonic saline is key.
What about N-acetylcysteine or bicarbonate? Do they help?
The data there is a bit conflicting, actually, not totally clear. Importantly, though, gadolinium contrast used in MRI should be avoided in patients with poor kidney function because of the risk of a nasty condition called nephrogenic systemic sclerosis.
Right, okay. Let's turn to diabetes now. It sounds like getting blood sugar control right before and during surgery is really crucial for outcomes.
Absolutely critical. First step is getting a full diabetic history, how well controlled they've been, any complications like DKA, any signs of autonomic neuropathy.
Why autonomic neuropathy?
It can make patients prone to low blood pressure during surgery and also gastroparesis, which increases aspiration risk.
Okay. And a high blood sugar itself is bad.
Consistently high glucose during surgery is strongly linked to increased morbidity and mortality. Higher risk of stroke, heart attack, death after carotid surgery. higher chance of amputation, graft failure after peripheral bypass.
So getting good control beforehand is vital.
Paramount. Ideally, working on it for weeks before surgery. HbA1c gives us that long-term picture. Some patients might even need hospital admission beforehand to work with endocrinology to get levels optimized.
And lots of studies back this up. The link between sugar levels and outcomes.
Yes, a significant amount of research. One study linked high sugar during surgery to increased 30-day death risk, more heart attack, stroke, kidney failure, wound problems. Another showed high sugar during hospitalization for light procedures led to more complications, infections, longer stays.
Even long-term control matters, like the HbA1c.
Yes, poorer long-term control, higher HbA1c, linked to more limb loss and cardiac events after lower extremity bypass. Conversely, strict sugar control after surgery seems to reduce wound infections.
And this isn't just for diagnosed diabetics.
No, some research suggests even in non-diabetics, higher average sugar or bigger swings in sugar can mean longer stays, more complications after non-cardiac surgery. Poor pre-op control in non-diabetics has even been linked to higher death risk around surgery.
Wow. So with all this evidence pointing to the risks, what are the current recommendations for managing it? Aggressive control.
Well, this is where it gets a bit nuanced. The data clearly shows high sugar is a risk factor. But large trials haven't definitively proven that aggressively treating it during surgery leads to significantly better outcomes in all cases.
So very tight control isn't necessarily the standard.
Some trials haven't supported super intensive control around surgery. Current recommendations generally aim for a target glucose below 200 milligdl after surgery in both diabetics and non-diabetic.
Okay, below 200.
Yeah. There isn't enough strong evidence right now to recommend even tighter control post-op or specific pre-op HbA1c targets that definitively improve outcomes.
And medication management.
Generally, oral diabetes meds are held on the day of surgery. High sugar is managed with insulin. Metformin is usually stopped 24 hours before due to that rare risk of lactic acidosis if kidney function drops. Insulin regimens usually follow hospital protocols.
Okay. Let's move to the adrenal system. Patients on long-term steroids need special attention.
That's absolutely correct. Patients on chronic steroids are at risk for a postoperative adrenal crisis. That can be very serious, even life-threatening.
So you have to screen everyone for steroid use.
Yes, really important to screen for past or present steroid use.
Hmm.
And also consider other causes of adrenal insufficiency problems with the adrenal glands themselves or the brain parts that control them, hypothalamus or pituitary.
And if they are on steroids or have stopped recently,
Yeah, for patients on, say, a certain dose of prednisone daily or equivalent, or who stopped glucocorticoids within the last year, further checks might be needed, like a morning cortisol level or a corticotropin stimulation test to see if they have adrenal insufficiency.
and what's the plan for surgery then? Do they need extra stress dose steroids?
Okay, for patients taking therapeutic doses daily, the current thinking is they usually don't need extra coverage as long as they take their usual dose.
Okay.
However, for patients diagnosed with adrenal insufficiency who are on daily steroids at a certain dosage or higher, supplemental stress doses are generally recommended around surgery.
How is that given?
A common way is IV hydrocortisone around the time of anesthesia induction, then maybe a continuous infusion for a bit after surgery before tapering back to their usual oral dose.
And for lower doses or shorter courses?
For lower doses, shorter treatment times, or alternate day steroids, extra coverage might not be needed. But you always have to remember steroids can have side effects around surgery, impaired healing, higher glucose, infection risk.
Right. Okay, let's dig into coagulation now. Preoperative anemia, low red cells, sounds like it affects recovery quite a bit.
It does indeed. Pre-op anemia is shown to increase morbidity and mortality after lots of different surgeries, not just heart surgery.
So you check for it, history, blood tests.
Yes, get a good history about chronic kidney disease or known anemia, check a preoperative hematocrit. Ideally, you treat any anemia before elective surgery if possible, and look for underlying causes like GI or urinary bleeding.
And treatment options.
Depends on the cause. Could be iron, vitamin, folate supplements, or erythropoiesis-stimulating agents, ESAs, to help make more red cells.
And transfusions, when are they used?
Generally limited. Maybe for patients with significant symptoms from anemia, active bleeding with a big drop in counts, or poor overall reserve and no time to fix the cause before surgery.
Because transfusions have risks too.
They do. Antibodies, hyperkalemia. So you weigh it up carefully, considering their heart status. For elective surgery, the focus is boosting their own production EPO, IV, iron, vitamins. Autologous transfusion or intra-op cell salvage are other options sometimes.
Okay. And with many vascular patients on blood thinners, what about routine coagulation tests like PT, APTT before surgery?
Well, they're often ordered routinely, but the patient's history is actually the most valuable tool for spotting bleeding disorders.
What kind of history questions?
Thorough medication history prescription, over the counter, any known family or personal bleeding disorders, unexplained or excessive bleeding, bleeding complications with past surgeries.
But the routine tests themselves aren't great predictors.
Unfortunately, no. They're relatively poor at predicting who'll have significant bleeding or a bad outcome, though really abnormal values might make the team pause, delay surgery, or take steps to correct them first.
Right. Now let's talk VTE prophylaxis preventing blood clots. Sounds like assessing risk and managing meds is crucial here too.
It is indeed critical. VTE risk, that's deep vein thrombosis and pulmonary embolism, is assessed based on individual risk factors and the type of surgery.
So history is key again. Prior clots, family history.
Absolutely essential. History of coagulation status, previous clots in the patient or family might suggest an underlying clotting tendency. And a full medication history is vital current and past anticoagulants, antiplatelets, any adverse reactions like HIT,
HIT.
heparin-induced thrombocytopenia. Also need to ask about known procoagulant states, genetic mutations, antiphospholipid syndrome.
And there are different ways to prevent VTE, meds, and mechanical devices.
Exactly. Pharmacologic options include various heparins, fondaparinux, warfarin, antiplatelets, the newer DOACs. And mechanical options are things like compression stockings, pneumatic compression devices for the legs, foot pumps.
Are there specific guidelines for vascular surgery?
Specific guidelines are a bit limited due to lack of big trials just in vascular patients, but it's generally recognized that vascular and cardiac patients are at higher VTE risk than general surgery patients.
Managing chronic anticoagulation around surgery sounds like a really tricky balance.
It truly is. Key questions are, when to stop the chronic blood thinner, and do you need bridging anticoagulation before and after?
Bridging, meaning using a short-acting one while the main one is stopped?
Exactly, like therapeutic doses of low molecular weight heparin or IV unfractionated heparin. Consensus guidelines give timelines for stopping meds like warfarin, DOACs, antiplatelets before surgery, depending on the drug and the procedure's bleeding risk.
And who gets bridging?
Generally considered for patients at high risk of clotting if their regular anticoagulation is stopped. Think atrial fibrillation with high stroke risk, mechanical heart valves with other risk factors, recent coronary stents, or a history of clots when stopped before.
And the decision depends on the surgeon's assessment of bleeding risk.
Yes. When to bridge, when to restart the regular drug after surgery, usually 12-24 hours post-op, depends on bleeding risk assessment. And everyone needs to know the reversal agents for these drugs, just in case.
Right. And what about bridging for patients not at high clot risk? Is it always needed?
That's less clear-cut. For patients not deemed high risk, the need for bridging is less defined. You really have to weigh the individual's clot risk versus their bleeding risk.
So it might not always be necessary.
Some data, especially from heart procedures like PCI, suggest that maybe continuing warfarin without interruption might even be safer than bridging in some cases. One study in AFib patients showed not bridging wasn't inferior for preventing clots and had less bleeding.
Interesting. And DOACs, direct oral anticoagulants.
No general recommendations for routine bridging with DOACs. Stopping times depend on bleeding risk, restart times vary, not much data on bridging them specifically.
Okay. Let's shift to infection. Preventing and managing that. Identifying active infection before surgery seems non-negotiable.
Absolutely paramount. An active infection significantly boosts the risk of surgical site infection and other serious complications.
Where do you look for infection?
Common sources are urinary tract, lungs, and ischemic limb, or infection around previous prosthetic grafts or devices.
So history and exam are key. Asking about fever, cough, urinary symptoms, graft tenderness, wound issues.
Crucial, along with a careful physical exam. If infection suspected, tests like urinalysis, chest x-ray, white blood cell count might be needed.
And if you find one,
Ideally, postpone the surgery. Start antibiotics targeted to whatever bacteria you find from cultures. But even with no active infection, prophylactic antibiotics given before surgery to prevent infection are generally recommended for vascular surgery.
and there are specific protocols for prevention. Skin prep, antibiotic timing.
Yes, patients usually shower with soap or antiseptic soap before surgery, keeping body temperature normal, good hydration, Good blood sugar control below 200 are also important.
And the antibiotics themselves?
Alcohol-based antiseptic for skin prep, usually. Prophylactic antibiotics given IV within 1 hour before incision, typically stopped after skin closure for clean or clean-contaminated cases.
What antibiotics are common?
First line, often cefazolin or cefuroxime. Alternatives like clindamycin or vancomycin for beta-lactam allergies or MRSA risk factors.
Yeah.
But specific choice should follow local guidelines and resistance patterns.
Antibiotic resistance, like MRSA, is a big concern, though.
It is a significant challenge. Methicillin-resistant Staph aureus infections are harder to treat. MRSA spreads by contact. Colonization often happens before infection.
So prevention is key, hand hygiene, contact precautions.
Fundamental strategies, yes. Identifying colonized patients, rapid lab reporting, ongoing education for staff, screening patients for MRSA pre-op and decolonizing positives has been looked at in other specialties.
But not widely adopted in vascular surgery.
It's been a bit controversial, less widely adopted there, yes.
Okay, let's talk nutrition now. Malnutrition before surgery sounds more common than you'd think, and impactful.
That's absolutely true. A significant number of surgical patients are malnourished beforehand, and that increases risks: poor wound healing, infection, lung problems, longer stays, higher costs, higher morbidity, and mortality overall.
And vascular patients are particularly vulnerable.
Often, yes.
Yeah.
Due to age, maybe mobility issues, poor diet, other conditions like diabetes, kidney failure, mesenteric ischemia. So a thorough nutritional assessment is essential pre-op.
What does that involve? History.
Detailed history about recent weight or appetite changes, functional status, any GI symptoms. Significant weight loss, like over 5% in a month or 10% in 6 months, is a big red flag.
Physical exam, too, and lab tests.
Yes, look for physical signs. For labs, serum albumin is often considered the best marker for chronic protein status. Low pre-op albumin is consistently linked to worse outcomes, adverse events, mortality, readmission, longer stays after vascular procedures.
So given these risks, what about providing nutritional support before surgery?
Well, while spotting malnutrition helps predict outcomes, the guidelines on who benefits most from pre-op nutritional support aren't crystal clear.
But it might help some patients.
Some studies suggest it can be beneficial in severely malnourished patients having major intra-abdominal surgery. If support is given, you aim for certain calorie and protein targets per kilograms of body weight.
IV nutrition or tube feeding?
A review suggested parenteral IV nutrition might reduce complications in GI surgery, but enteral tube feeding is generally preferred if possible, safer, more cost-effective. If pre-op support is needed, it's often recommended for 10-14 days before major surgery, if the surgery can wait.
Okay. Finally, let's touch on frailty assessment. Sounds like this is becoming increasingly important in planning.
It absolutely is. Frailty means decreased physiologic reserve, makes someone more vulnerable to stressors, like surgery, and predicts poorer outcomes.
So it's about vulnerability, decline in function.
Exactly. Increased vulnerability from loss of physical and mental function, weakening of multiple organ systems. Frailty scores try to make that assessment more objective.
Is there a specific score used in vascular surgery?
A modified frailty index, using 11 variables from the NSQIP database, is common. Things like functional status, diabetes, COPD, heart failure, history of heart attack, stroke, peripheral procedures.
And higher scores mean higher risk.
Consistently associated with increased morbidity and mortality in vascular surgery, especially after carotid procedures, aortic aneurysm repair. More frail patients have higher risks after AAA repair, more complications, death, readmission after carotid endarterectomy.
Can you do anything about frailty before surgery, like prehab?
There's some emerging evidence in primary care that pre-op strength training and nutritional support might reverse frailty sometimes. But the benefit specifically in vascular surgery isn't quite clear yet, though some studies suggest supervised exercise might reduce cardiorespiratory and kidney complications after AAA repair.
Well, this has been an incredibly thorough, really insightful overview of the whole preoperative process for vascular surgery. It truly highlights just how much meticulous thought and planning goes into it.
Absolutely. As we've seen, is genuinely multifaceted, demands careful thought about a huge range of factors across all the major organ systems, the level of detail, the risk reduction strategies. It really shows the commitment to patient safety and getting the best possible outcomes.
We certainly hope this deep dive has given you, our listeners, a much clearer picture of everything involved in preparing for vascular surgery. The sheer level of detail, the personalized approach, it really underscores that dedication to each patient.
It really does.
Thinking about everything we've covered, from cardiac risk, lung function, kidney status, nutrition, frailty, What single aspect do you think might play the most significant role in predicting a successful outcome after vascular surgery, and why? It really makes you appreciate the interconnectedness, doesn't it?
That's a great question to ponder. And it really hits home how complex this is. Each area, heart, lungs, kidneys, metabolism, nutrition, overall frailty, they all interact in such intricate ways. They influence resilience, the ability to recover well. Often, it's probably the interplay between these factors, not just one thing in isolation, that really shapes the final outcome.
This deep dive has really just scratched the surface of an incredibly detailed field. If you have more specific questions about any aspects of preoperative evaluation or vascular surgery we've touched on today, we definitely encourage you to explore further with trusted medical resources and, of course, your own healthcare providers. Thank you for joining us for this in-depth exploration.